Hello everyone, my name is Deepti Deshpande and I'm an assistant clinical professor of pediatrics in a voluntary role at Columbia University Medical Center. And thank you for the opportunity to present some of the work we've done with the Immunodeficiency Foundation. Let's talk about leveraging patient-reported data during the COVID-19 pandemic. These are my disclosures. The work that I'm presenting today was started during my fellowship, and I continue to work on it as a part of my voluntary faculty role at Columbia. This is entirely unrelated to my work at Regeneron. Individuals with inborn errors of immunity frequently have variable degrees of immune deficiency and/or dysregulation. In general, they tend to be at risk of infections and potentially worse outcomes, in addition to having several comorbidities. And as the COVID-19 pandemic was rapidly spreading across the United States during early 2020, there was a need to understand the risk and impact on these vulnerable individuals. These surveys were conducted by the Immunodeficiency Foundation with a goal to understand both the direct and indirect impact of COVID-19 on individuals with inborn errors of immunity or primary immunodeficiencies. The IDF conducted voluntary unincentivized surveys during this time period. The initial survey was completed in March 2020, and there are 3 subsequent surveys that were completed since then. These are ongoing surveys, and as a part of a collaborative agreement between Columbia University Medical Center and the Immunodeficiency Foundation, de-identified data were provided and analyzed. There were over 2,000 voluntary survey responses expressing interest among over 22,000 emails that were sent by the IDF. The initial 4 surveys assessed underlying disease characteristics, including immune deficiency diagnoses, comorbidities, the impact of COVID-19, and health-related quality of life. This was a nationally representative cohort of adults and children with PIDs, included mostly adults. And most of the analyses, therefore, were limited to adults with a known primary immune deficiency diagnosis. Predominantly, we had primary antibody deficiencies, and common variable immune deficiency, or CVID, was the single most common diagnosis. And during the time period of COVID-19 and the time of these surveys, the use of protective personal equipment as well as isolation were common in this cohort. Our initial goal was to characterize COVID-19 illness, with an objective to characterize COVID-19 illness in individuals with PIDs and assess clinical outcomes. So of those with a known PID diagnosis, we had 16 individuals that reported physician-diagnosed and/or PCR-confirmed COVID-19 illness. Of those 16, 3 were hospitalized, 2 with CVID, and 1 with hypogammaglobulinemia. All 3 had relatively short hospital stays, and none of them required any ICU stay. In general, the strength was in numbers. We had a large nationally representative cohort, and at that time, publications thus far had not reported many hospitalized cases with immunodeficiency. However, it was important to keep in mind that these surveys were done early in the pandemic, which may or may not have captured the full extent of the impact. And additionally, at that time, there were limitations resulting from inadequate testing, resource availability, especially during that early phase. And the majority of cases in our cohort were not PCR-confirmed cases. In addition, there is a voluntary responder bias potential in voluntary surveys. A recent publication of collaborative international work presented retrospective data on 94 patients with inborn errors of immunity and COVID-19 illness. And the risk may vary with specific underlying immune pathway affected. they found a substantial subgroup with inborn errors developed milder COVID-19 disease. And very similar to what we had seen early on, they found that most patients with humoral defects had milder disease. Again, risk factors for severe disease and mortality appear to be similar to the general population. As we were assessing the impact of COVID-19 and characterizing individuals in our cohort, we had the ability to meaningfully characterize asthma in individuals with PIDs. Asthma has been well characterized in adults, and the reported national asthma prevalence is about 7.7%, and 5 to 15% have severe asthma. In addition, uncontrolled asthma is associated with a lower health-related quality of life. In terms of primary antibody deficiencies, they account for about 50 to 60% of inherited disorders among inborn errors of immunity, and they tend to have a lower health-related quality of life as compared to a gender-matched population. In primary antibody disorders, there is a high asthma burden. The reported asthma frequency in CVID is about 30%. So although asthma has been reported frequently in primary antibody deficiencies, data remain limited on asthma severity, control, and the currently used treatment strategies. So our objective was to characterize adults with asthma with underlying primary antibody deficiencies, and specifically defining the frequency of asthma, characterizing these individuals, and then assessing the relationship between asthma, asthma severity, and control with perceived physical and mental health. We used information from the initial 2 surveys that provided detailed baseline data on the primary immune deficiency diagnoses as well as asthma. We excluded anyone that did not have a known primary immune deficiency diagnosis, and we had 576 adults with primary antibody disorders included in our final analyses. Perceived physical and mental health were assessed using 2 questions that asked, in general, how would you rate your physical health, and in general, how would you rate your mental health, including your mood and ability to think. Good perceived health was excellent or very good, versus poor perceived health was a response that said good, fair, or poor. Our predictors included asthma, asthma severity, and asthma control. We assessed the relationship between asthma and poor perceived physical and mental health, and found that severe asthmatics, those on steps 5 or 6 of asthma therapy, had 3 times higher odds of poor perceived physical health, and those with uncontrolled asthma had 2 times higher odds of poor perceived physical health. There was no impact of asthma, asthma severity, or control on perceived mental health. In conclusion, asthma is common and occurs in about 40% of individuals with primary antibody disorders. About 1 in 5 patients with PADs have severe asthma, and about 1 in 3 patients have uncontrolled asthma. Severe asthmatics and those with uncontrolled asthma had higher odds of lower perceived physical health independent of other comorbidities. This is the first study, to our knowledge, that characterizes asthma severity, control, and its impact on perceived health among individuals with primary antibody disorders in a nationally representative large sample of patients. Again, limitations with survey data include a voluntary responder bias, potential misclassification bias for asthma and/or allergic disease. And optimizing asthma control may be a relevant strategy in improving physical well-being. Our next steps were assessing the impact of COVID-19 pandemic on physical and mental health among individuals with primary immune deficiencies. Individuals with inborn errors of immunity or primary immunodeficiencies have variable degrees of immune deficiency and/or dysregulation. Comorbidities tend to be common, with a need for frequent access to care. About 1 in 3 individuals with PIDs report fair, poor, or very poor perceived health versus good or excellent. And they also tend to report a lower health-related quality of life than a gender-matched US population. A study of Italian patients with primary antibody disorders during the COVID-19 pandemic showed worse health-related quality of life, specifically in those at risk of anxiety or depression. Patients in that study also reported anxiety about running out of medications during the pandemic. They did not report any impact on health-related quality of life due to transition to remote assistance programs. While studies have revealed COVID-19 related negative impact on mental and physical health in the general population, data remain limited in individuals with PIDs. Therefore, our objective was to assess the impact of COVID-19 on healthcare access and its relationship with perceived physical and mental health among adults with PIDs, specifically to determine the frequency of healthcare access issues and determine the relationship between healthcare access issues and perceived negative impact on physical and mental health. Perceived negative impact on physical and mental health due to COVID-19 was assessed using 2 questions that asked, please tell us how much the COVID-19 pandemic has negatively affected your physical health, and please tell us how much the COVID-19 pandemic has negatively affected your emotional health. And negative or minor negative impact was compared versus a moderate to severe negative impact. And our predictor was healthcare access problems due to COVID-19 that included issues with supply or access to immunoglobulin replacement or other medications and missed appointments. We combined the initial 3 surveys that provided information on baseline disease and comorbidities, access to care, as well as health-related quality of life. We excluded anybody without a definitive PID diagnosis. And in the final analyses, we had 565 adults with primary immunodeficiency. Baseline demographic and clinical characteristics among 565 individuals showed that 86% were female and majority were non-Hispanic white. Antibody defects were the most common diagnosis, and 90% of those were on immunoglobulin replacement. The baseline mean PROMIS global physical and mental health scores, looking at health-related quality of life, were below the national average by gender, as expected. In terms of COVID-19 related impact, healthcare access problems were reported by 63%, and a moderate to severe perceived negative impact on physical and mental health was reported by 22% and 53% individuals respectively. We found that individuals with primary immunodeficiencies that experienced COVID-19 related healthcare access issues were 3.6 times more likely to report a moderate to severe perceived negative impact on their physical health and 1.7 times more likely to report it on mental health. This is using a multivariate logistic regression model adjusted for age, gender, immunoglobulin replacement, presence of any comorbidities. In conclusion, healthcare access issues are common during COVID-19 among individuals with PIDs. Optimizing healthcare access may be a relevant strategy in potentially improving perceived health and well-being. The study provides insight into a potentially modifiable factor to help improve perceived health. And in a nationally representative large sample of adults with PIDs, limitations are similar to what we've discussed previously, including voluntary responder bias, potential for misclassification bias, and additional studies are needed to further explore the determinants of physical and mental well-being, as well as what is their longitudinal impact on health-related quality of life as we navigate through this global COVID-19 pandemic. As I end, I want to thank our survey participants. Your contributions and participation in these surveys has truly helped advance the science and our understanding of primary immunodeficiencies and has helped improve the lives of those with PIDs. Collectively, data from Immune Deficiency Foundation surveys over time has been well cited. Patient perspectives and patient-reported data are critical to our continued progress in understanding and managing this group of diseases. I also want to thank the Immune Deficiency Foundation, Chris Galchuns, and the Immune Deficiency Foundation staff for their tremendous hard work and support. I also want to thank Dr. Angela Chen, who's worked with me in some of these data, and Dr. Joshua Milner and Dr. Jordan Orange for their support and mentorship. Thank you for the opportunity to share this work with you, and once again, a very big thank you to our survey participants.
Okay, thank you so much for that presentation, Dr. Deepti Deshpande. So this is Christopher Skalchuns, Vice President of Research at the Immune Deficiency Foundation. So before we get into the Q&A, please remember that each individual's treatment and condition is unique. The information presented during the session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. At this time, please join me in thanking Dr. Deepti Deshpande from Regeneron Pharmaceuticals and Columbia University Urban Medical Center for that wonderful presentation. And please say welcome to the Q&A portion of the session. So, I want to say a few things about this before we get started, if I may. So obviously, when the pandemic started, it was an incredibly scary time for our community. We all know that one of the first things we were warning about was the potential for those who are immune compromised to suffer more severe course of disease. So IDF was quite fortunate that we rapidly got out our very first survey for COVID in March, at the end of March, just when really the first cases were starting to hit here. And the wonderful thing about this is we were really trying to do this as a way of acting as an early warning system for our community. And we really had to rely on our patient community and those of you taking the surveys to do that. And we wanted to look at things like, is there a more severe course of disease? Are they having problems accessing medications, healthcare appointments? Just so that if we started to see an indication of these things, we could jump and move on it and activate our communications team, our public policy team, to advocate on behalf of people in our community. But right after we started this, and this is a great example of collaboration and the relationships we have, Dr. Deshpande reached out and said, hey, Chris, I'd love to be able to help IDF with this incredibly important project. No one was able to get surveys of patients out in the field as quickly as we were. And thank goodness she did, because with all of our expertise, advice, and hard work, we put together the questionnaires, and we're able to leverage that into published manuscripts in such a short period of time. So I really just want to thank Dr. Deshpande for that and give everyone kind of a hint on the background of that. Dr. Deshpande, I do want to ask you, what do you think we can expect in the future? We've committed to doing at least one more COVID survey. What types of questions do you think we want to get at and answer and bring back to the community?
Right. I think, first I want to thank all of the survey participants, and we could not have done this without your help. And I think this is really important information coming from you. And as we started out the survey, Chris mentioned, we were very early in the course of that pandemic. And as we tried to figure out what are some of the direct impacts, are people getting more severe disease or not, but also some of the indirect impacts, with our healthcare access issues, anything that we were not thinking about. But again, keep in mind, we were limited to some extent because we were so early in the pandemic. And as things unfolded and the pandemic raged across the country, I think this next survey will help us look at it more broadly and look at both the direct impact, indirect impact, and over time understand better for our community, what did this mean? What did this mean for their health? What did this mean for their quality of life? And, vaccinations have been up and going, and, we could potentially add more questions to understand how that process has been going. And I think this is really critical information that, would come from your end, again, at a different point in this pandemic to help us understand that picture more broadly. But thank you again for this opportunity to be a part of this really important effort from the Immune Deficiency Foundation.
No, of course. And as you mentioned, the idea in the beginning was to act as a bridge to larger, more robust studies, clinical studies as well, that we knew would happen. And others finally started catching up. So I think the work that we did, based on the generosity of those who've taken the surveys, did exactly what it was supposed to for that time in the pandemic. And I think the fact that you had the foresight to be able to add some additional questions, be able to get us to not just inform, as we saw in the presentation, about COVID-19, but we had gems in there about asthma, right? And the control of that didn't exist in the medical literature to that point. And that's the type of collaborations that we work on together. So a general topic and question for you, Dr. Deshpande. So you have feet kind of in both academia at the moment and, of course, with Regeneron, who became very popular during this pandemic, right? But my question is, with a foot in kind of both of those worlds, how do you see patient-reported outcomes and patient-reported data fitting into clinical trials and things like post-market studies?
Right. And, at this point, I'm going to say I wear two hats. One is my, industry hat, and one is my academic hat. I still work as voluntary faculty at Columbia, and that's how I'm involved with the Immune Deficiency Foundation. So I do want to, make sure that anything I say right now is not as a Regeneron employee, but more as a patient advocate and a faculty who's working in academia with our communities. And so I just want to put that out there. This is not work I do at Regeneron. But I think, overall, as we think about clinical trials, patient-reported outcomes and patient-reported endpoints are important. How do we impact what matters to our patients and communities? And as we run trials, we're thinking about that more and more, and how to bring in endpoints and outcomes that really match that that aspect of what is it that matters, right? I mean, we can look at histological outcomes and other more objective outcomes, but these are really important aspects of understanding how we practice medicine and how we leverage that to help improve the lives of people. So I think it's really important as we think about it. I wear that hat kind of dually every day and think about, what can we do better? What can we do differently? And what matters? So that's a really important question.
Right. And I think one of the important takeaways from that is there's been a change, I think, in the last few decades, where now there's an emphasis and a push to continually obtain patient feedback on therapies, interventions, not just to collect the data, but to improve the processes and how they're developed, to kind of inform in on itself. So the voice of the patient, which is something IDF has been, doing since our founding in 1980, we continue to collect and do that, whether it's with surveys or if you see clinical trials advertised on our website and are in the news section and those sorts of things. It's important that our audience realize that without anyone volunteering for trials and studies or surveys, we wouldn't have the advances that we have now. So I just ask everyone who's listening to, when you come across a trial, carefully consider the trial, read everything you can about it, We've got an excellent section on the IDF webpage explaining what makes a good clinical trial, what they're about, how they're run, questions to ask your provider and people running the trial. But certainly the advances for PI and those in our community can't occur without people volunteering their time and themselves to advance research.
And I think, your voices are important, because I'm going to add, even with, patient care, how we practice medicine. And it's a joint decision and a joint discussion of how we practice medicine, clinical research. And I think your voices are important no matter what that platform is.
Yeah, I think we're in total agreement there. Well, I think at this time we're heading up to about 11:30, so I think our time is just about at an end here. So thank you so very much, Dr. Deshpande. It really has been an honor, not just to have you join us today, but the fantastic collaborative work that IDF and Columbia did through the course of this pandemic. And I look forward to us working together as we round out and finish out the rest of our look at COVID. So thank you so very much, Dr. Deshpande.
Thank you. My honor and privilege to work with both the Immune Deficiency Foundation and all of our survey participants for doing the work they're doing. So thank you. Thank you for this opportunity.